Where is he?
I'm here.
All right. So any minute now?
Yeah. 2 minutes.
So Dr. Khalid, you know, Manju got married.
Who?
Manju.
Oh, at last. Well,
last.
congratulations. Well done. Well done.
Thank you.
You did it. Congratulations, Manju.
Thank you.
So he chose COVID time to marry, no, so that he doesn't have to give any party.
Because it's cheaper.
Oh, smart move. Big congratulations.
Saved a lot of money.
Congratulations, man.
Yeah.
Well done. Well done. I don't think you will regret it. Don't listen to those, you know,
I hope so.
bachelors. They envy you all the way.
So final 3 to 4 minutes to go. YouTube live link is on.
Okay.
We are admitting all participants.
Yes.
So within 5 minutes, we can start.
Sure. We are 4:58. In a minute or two, probably we can start.
Yes, sir.
So,
Once you say go ahead, I'll start recording too.
Balu, there are 69 people
Record
right now.
Yes, sir.
Yes.
Yaar? No, yeah, okay.
Srini, mute yourself.
Sure. Chintan, also we can record once we start the YouTube too.
Great.
George, can we start?
Hello? Yeah, ready.
Chintan, ready?
Yes, sir.
Yeah.
Yes, sir.
Yeah.
We can start.
Fine.
Balu, you want to say a few words or should I start off with a...
Yeah, I'll do that 2 minutes, sir.
Oh.
Nico, now you can stop sharing so that we can go for a speaker view.
No,
or
that's fine.
slide.
Yeah, this is fine.
Fine?
This is fine. This is fine.
Okay,
No, fine.
perfect.
No issues.
Go ahead, sir.
Welcome all to this first event, webinar, international webinar on thoracic surgery, where we are going to discuss about the keyhole approach to thorax, giving emphasis more on minimally invasive surgery. And here we have international faculties, one faculty from UK, Dr. Khalid, Dr. Alan from Hong Kong, Dr. Lee from Shanghai, and Dr. Rajinder from New Delhi, who will be sharing their experience on minimal invasive approach to malignancies in thorax. We have gone a long way since the open surgery, then to the minimal invasive surgery, the VATS, which has now become the modality of treatment. After that, we have also gone ahead to more minimal invasive, that is uniportal. And also we've gone conservative from the initial lobar resection to sublobar resections. In a number of cases where the initial lobar resection was the gold standard, now literature is there to support the use of sublobar resection in selected patients. So we'll be discussing a lot of these issues in this webinar. I hand over the session to our moderator, Professor George, who is the professor, Department of Thoracic Oncology, Tata Memorial Hospital, the largest hospital on cancer in India. Professor George, on to you.
Thank you very much, Balu, for the introduction. So I think without further ado, we'll go on to the talks. We are lucky enough to have 4 really excellent speakers, and they've been gracious enough to accommodate a few requests we made to tweak the talks also. So we'll start off with the first one. We'll be progressing from a multiportal VATS to a uniportal VATS to a subdivided approach. And finally, after the lung talks, we'll have a talk on robotic and VATS approaches to thymus also. So first on is a very good friend, dear friend of mine, Professor Khalid Ahmed. He's a consultant thoracic surgeon at Southampton General Hospital. And he will be speaking to you about the nuances of multiportal VATS, and as on our request, a bit about thoracic anatomy, microanatomy, mediastinal lymph node dissection, etc., etc. Prof, you're on.
Thank you very much. I hope you can hear me. I'm going to share my view with you. Right, we've got it. Can you hear me well?
Yes, yes.
Great.
Khalid, before you start, a request to the delegates. If you have any questions, please send it in the chat room, and whatever questions you have, we will convey to the moderator, who will answer it to the speaker. He will answer it at the end of the session.
Okay, now how do I do this sharing? New share, or what do I do? Live, stop share. Your screen, you're on.
You're on. You're
okay.
on.
Yeah, but when okay, fantastic. Okay. Well, thank you very much for having me. I need some time, therefore, I will just get on with life. I have no conflicts to declare. What I will be talking about today will be the superiority of the triportal against the gold standard, which is the thoracotomy. And I hope also to talk about how to construct the ports. And this is probably the salient features of today's talk, because it makes all the difference between multiportal and uniportal. And I will explain. I will also have a word or two about the port limitations and complications. And I will hope to approach the philosophy of appropriately invasive surgery. Because I'm the first speaker, I'm going to set the scene for the debate about multiportal versus uniportal. So without further ado, the history of VATS labectomy takes us back to 1933, where the very successful pneumonectomy was done by a thoracotomy by someone called Everett Graham, and he operated on another doctor, Dr. Gilmore, who was a gynecologist. And the operation was a success. The patient lived for 24 years, and he, in actual fact, outlived the surgeon. This sets a very difficult, standard. In 1933, the patient who had lung cancer lived for 24 years. If our patients today live for 5 years, I'll be surprised. Anyway, that's not the point. The point is, it took about 60 years for us to move from thoracotomy to keyhole surgery when Roviaro, Italian from Italy, from Milan, described the first VATS procedure as we know it from an anterior approach using triportal surgery. The nearest I could get to give you a gist of what has happened on that day in Quebec in 1933 is this video, which is a courtesy of my friend from the Netherlands, Walter Oosterhuis. And have a look at this. A patient who has had pneumonectomy, 1933. Notice the gloves, they're dry. Also notice that the scalpel is being held by 2 hands. Again, look at this sort of artistic entry into the chest. There was no diaphragm in 1933, so everything depended on the muscles of the surgeon. They were cutting everything. And for the bleeding, they would stop the bleeder with a hemostat, and they will have something like 100 hemostat. Look now at the gloves. how they imbibed all the blood. And in those times, to gain access to the chest, you have to remove the rib. So a lot of destruction. Think about these interleukins which you're generating. This is the lung, which has been removed. And then the hemostasis is performed. All these hemostats will be probably tied by a chromosized catgut. Those who do not know that, please don't ask. It's embarrassing. It tells our age. And the chest is closed again with chromosized catgut, interrupted. Huge destruction and huge disturbance of the immune surveillance of the cancer. Compare that thoracotomy to this end result of keyhole surgery or triportal keyhole surgery. Very small, little, nice scars. So it looks nice. So definitely there is a cosmetic benefit. There are fewer complications if you go keyhole surgery, and there is less need for analgesia and antiemetics and what have you. The recovery from keyhole surgery is by far better than thoracotomy. And as a result of this early recovery, there is early return to work. And also we found that there is early application of the adjuvant chemotherapy because they tolerate it better. And that might have also an implication on their long-term survival. We also noticed that redo surgeries are much easier in VATS patients rather than thoracotomy patients. Is there an evidence that VATS is much better than thoracotomy? We need evidence for anything we do. Of course, there is one. I have chosen this one. This one is made in the UK. This is the Violet study, which has been started a year ago in early 2019. And what the Violet is looking for is randomization of patients into open thoracotomy versus conventional VATS, usually triportal. This is the largest randomized controlled trial that looks into this specific question. And it has actually reported initial results by the end of 2019 in September in a meeting in Barcelona. Eric Lim has given us some gist of the interim results, because the final results are going to be published in 2024. So these are 9 centers which has randomized patients for either open or VATS lobectomies. And there seems to be already a difference favoring VATS. So yes, we do like VATS. When we started our experience in Southampton with VATS, the principles were straightforward. Single lung ventilation, 1 to 4 ports, operating via the monitor rather than through the hole he created in the chest. Strictly no rib spreading, anatomical dissection of the hilar structures. Why anatomical dissection? Because there has been an incident. If you remember Ralph Lewis, 1995, he was doing something called simultaneous stapling of the hilar structures. This was never popular, just forget about it. Lung retrieval in a bag, yes, because that helps in preventing port metastasis. Now things have changed. We've evolved. In 2020, single lung ventilation is not even needed. There is something called awake surgery, in tubeless surgery. You don't need it at all. 1 to 2, 4 ports. The number doesn't matter at all now. Operating via the monitor. What monitor? There is something called 3-dimensional goggles and goggle-less 3-dimensional monitors, and there is something called virtual reality goggles. Things are changing, we are evolving. Strictly no rib spreading. So what's wrong with rib spreading? I don't know. I personally don't use spreaders, but there again, I can understand that it might cause pain, and pain is everything. What we are talking today about is pain. But there again, I mean, the Toffier retractor has been exchanged for something else. The wound protectors, they are also sort of retractors, more or less. The only thing that didn't change is the anatomical dissection of hilar structures. This is solid. Now, during a thoracotomy, we cut a lot of these muscles, big things, latissimus, serratus, God knows what, teres major, and that's too much and causes a lot of damage. Now that we have moved to keyhole surgery, the emphasis has shifted towards microanatomy, towards the intercostal space. Where is this subcostal neurovascular bundle? Where is the artery? Where is the vein? Where is the nerve? Are we interested in measuring the distance of the intercostal space at the back? There's a difference between back and front intercostal spaces, and the innervation of each. And also the distance of the nerve from the subcostal groove anteriorly and posteriorly, and also the insertion of those intercostal muscles, thoracis intimis, thoracis internus, thoracis medius. We need to know all these in detail. And the reason for that is you want to generate your ports with all this in mind to end up with painless surgery, i.e. zero pain. This is what you get. We know that the pain occurs from abusing the intercostal nerve like that, or from energy being dissipated in the middle of the intercostal space. So these are the things that you should avoid totally. Now, I'm going to give you a synopsis here of how I generate my ports. And again, this is a personal choice. I usually stand at the back of the patient, the assistant at the front. The three ports that I operate, or we operate with in Southampton, are based or centered around the hilar axis. And this hilar axis actually is in the middle of the chest. I always start with the anterior port, which is usually about 3 centimeters in length, and it is generated in either the fourth or the fifth intercostal space. And I'll tell you in a minute why and how. Now, once we've done that, we introduce the camera and we have a look at the diaphragm. At the highest point in the diaphragm, where it intersects with this mid-hilar axis, we generate the camera port or the inferior port. And then we put the camera back into this inferior port, and it stays there for the rest of the duration of the operation, never changes. And then we pay attention to generating the third port, which is about 1 breadth away from the medial margin of the scapula. Always have to think about, if I have to open up a thoracotomy, how is it going to lie? Because when you need a thoracotomy, you're going to join the third and the first ports. This gives you your fine, nice triangulation with very good convergence angles. And the use of the 30-degree camera will give you very good views anterior to the hilum, as well as posterior to the hilum. And it is my practice, actually, to flip the lung forward and backwards all the time. This is very common, and I get excellent views. It is just akin to the thoracotomy. What you see is what you get. If you need to just do a thoracotomy, you are in the right place. You just do the thoracotomy and go for it. I must emphasize that the surgeon will be using both hands at all times. Now let us go to the nitty-gritty things. This time I'm describing this in the left chest, mind you. So by pushing the shoulder down, then you know the lines or the outlines of the scapula, and then you make note of the mid-axillary line. Your first port is going to be somewhat horizontal with the angle of the scapula, and you feel for the intercostal spaces. And you go for the widest, either the fourth or the fifth. The widest of the two, you should go for. It's usually about 3 centimeters in length. When you open up the skin and the subcutaneous tissue only. You do not cut muscle. I repeat, do not cut muscle. So once you have had a gist or a feel with your finger about where is the rib, all you have to do now is to prepare your visiport. And this is very crucial for what's going to happen next. You need a visiport. You connect the carbon dioxide and you start it. And you put your scope inside the VisiPort, which will allow you vision and introduction of the VisiPort and the vision. And then slowly you push in without much force, and you can see your way through. This will sort of separate the muscles, the intercostal muscles, until you can see the lung inside. If there are adhesions or anything like that, then it is safe to do this. You won't be cutting any adhesions. And then you take out the trocar and put the camera in to see the magic of the carbon dioxide. Look at this. It collapses the lung down and pushes the diaphragm away. And then here, then you make a note of your mid-thoracic axis, which we talked about earlier. And then you start poking from outside. You poke with your finger to identify where is the intersection of this with the highest point in the diaphragm. So this is what you want. This is exactly the point where you want to make your inferior port. So once you have decided, then you just cut a 1 centimeter horizontal incision and then put in a robot and then just dilate it. And then you shift the VisiPort from the anterior port to the inferior port. And at this point, you inflate the cuff of the VisiPort, which I call the Mexican hat. And that makes it self-retaining. It won't come out. And also will prevent blood coming to the tip of the port. And then you put your camera through that port, the inferior port, and it stays there for the duration of the operation. Now, you pay attention to dissecting the anterior utility port by finger dissection, nothing else. There's no diathermy at all. And the aim is to try to introduce 2 fingers. That's all you need, 2 fingers. No energy release whatsoever in the intercostal space. And the reason for that is you're going to put the Alexis device. And the Alexis device is a very good retractor. If you can push 2 fingers in, then the Alexis will give you all the space you need to operate. So Alexis goes in, and the cuff of the Alexis is sort of cuffed back, flush with the chest wall. And at that time, you have to stop the carbon dioxide because you've got an open chest. So it doesn't make sense to keep on giving the carbon dioxide. And then you pay attention to introducing your third port, as we said earlier on. You make a small incision, 1 finger breadth from the scapula, and you should be able to put at least your pinky finger inside that port. And there you got it. That's your triangulation. You work with 2 hands at all times. And here I'm introducing the final analgesia just before closing the chest. And it's very vital to understand what is happening here. This is a butterfly giving set with the general anesthetic, which is bupivacaine, injected into the intercostal space, and inject anything from space 2 to space 8. Usually use about 30 mils of volume, and the combination of the dexamethasone and the bupivacaine is for each 10 mils of 0.5 bupivacaine, you need to give 1 mil or 3.3 milligrams of dexamethasone. I have seen a major shift towards painless surgery using this technique of generating the ports, and also at the end of the operation, blocking with dexamethasone added to the bupivacaine. As a tip, always start with the anterior port because you don't know where the diaphragm is. You don't want to be below the diaphragm when you put an inferior port. The use of carbon dioxide is a personal choice, but I think it helps. These first 5 minutes of the operations are vital for you to collapse the lung, and it can stay collapsed for the rest of the operation. Now, you need to understand the ergonomics of this triangulation. You need a convergence angle which is enough for you to operate comfortably. If you put these anterior and the posterior ports very close together, then you will have a very short convergence angle, and the vision is not very good, and the motion of your instruments is not optimal. also try to avoid this, the scissoring and fencing. We do this sometimes without really noticing, but it's a taboo. Everyone says it's bad, and I agree it's bad. I don't know why, but it is bad. Look at this. This is me doing something, and you become confused which hand is crossing where and what is retracting and what is diathermizing. Again, this is the greatest sins of all that sort of practice is you have to avoid working towards your camera. If you do that, then you get complete disorientation. Right becomes left, left becomes right, and you can't move anywhere. So, limitations of the intercostal space, you have to remember that the intercostal space is bound by two ribs. That's a bony aperture. And therefore, because it is limited, it is not suitable for solid masses. For instance, if you've got a big thymus, which is calcified, you can't bring it through a small 1 centimeter intercostal space. The lung comes out because the lung is spongy, and the lung can deform while it is coming out through a very small aperture in the chest. This is what is known as the hourglass deformation. Just like this fellow here. This deformation is important for extraction of or retrieval of the specimen. And the addition of a bag makes it easier for the lung to deform and slide within the bag. If you try to extract the lung directly without a bag, it will tear because all the force will be transferred to the lung directly and not to the bag. It will tear. Now, because of that, if you exert too much pressure on something which is not deformable on the ribs will fracture. There's no doubt about it. However, there is an answer to that if you are, if you want to do sort of a planned fractures of the ribs. There is something called the French window, and I'll show you what it means in a minute. But there again, if you compare the intercostal VATS to something like the subxiphoid VATS, here there is a big difference. The subxiphoid is by far superior, and I'm sure Jean Li is going to tell us about it. So what is this French window? French window is you make a deliberate cut in the rib here and here as you're opening at the top of the rib of the space you're going to open up, and then you fulcrum it down on the intercostal muscles, and you've got this gap, and that will help you in retrieving very large tumors or tumors that will not deform, calcified something, solitary fibrous tumor, thymic calcified something, mediastinal calcified teratoma, etc., etc. Now, Professor Gossot from France always emphasized that we shouldn't be too picky about being, too minimally invasive. That is not appropriate. What is appropriate is what is the right approach or access for that patient with that lesion in the chest. This is important. So the concept of 1, 2, 3, or 4 ports, it depends on what you want to do inside. For instance, if you want to do just the pleural biopsy and talc pleurodesis, all you need is just 1 port. If you want to do a sympathectomy, you need 2 ports. If you want to do lung resection, in my opinion, it might be either 3 or 4 ports, and so on. So horses for courses. Sometimes the mini thoracotomy is the best approach. Sometimes the standard thoracotomy is the most minimal thing that is required. Sometimes the extended posterolateral-anterior thoracotomy is needed. And sometimes you need the largest aperture a human being can generate in the chest. Look at this fellow. It's amazing. This is it. This is solitary fibrous tumor. And this required double space thoracotomy and removal of ribs. There was no other way to dissect it off the diaphragm or from its blood supply on the chest. So yes, appropriately invasive surgeries, whether sometimes thoracotomy is the appropriate one. Now the question arises, is uniportal a natural progression from multiportal VATS? Now we know that multiportal VATS is a progression from thoracotomy, and most surgeons are not doing thoracotomy as a first choice. But if we decide that uniportal is a progression from multiportal, then we should all change, including myself. We should change to become uniportal surgeons. I don't think so. I really don't think so. I'm giving it to you on a silver plate. I admit uniportal VATS or univats can do everything that multiportal VATS can do. But is it better? Do we have evidence that uniportal is better than triportal? And if so, if this evidence exists, should we all change? Is multiportal something of the past? Will I be an old surgeon who's doing a multiportal? Am I a dinosaur? Or alternatively, is univats a gimmick? Is it going to disappear because it is just like Ralph Lewis's simultaneous stapling? No one took it up. Of course, this is not happening. It's not a gimmick. We know that. Alan will tell us in a minute. Half of the world's surgeons are now going into uniportal, and it has been popularized like no other approach before. So we need to be careful. I've collected a bit of evidence for you, and Alan can probably help me with discussing this later on. There is a systematic review and meta-analysis published by a team from Australia and also by Diego from Spain. And they were looking into the evidence between uniportal and multiportal. They have chosen these 8 studies, okay? None of them was randomized control. One of them was propensity matched, and the majority or the rest were observational studies, okay? So how these qualify for a systematic, beyond me, because systematic reviews should include randomized control trials, but there has been no randomized control trials. I might be wrong, but Alan can correct me. I can't think of a single randomized control trials between uniportal and triportal. So I'm slightly sort of skeptical about their results, because they say that there is less overall complications and the length of hospital stay and the drain dwell time is in favor of uniportal VATS. So this systematic review, when you hear systematic review, and it has concluded, that there is a favorable outcome to uniportal over multiportal, I get really distressed. I think I'm a dinosaur. I'm not really following up. However, as they say, the devil is in the detail. Look at this. This is what they based their statistics upon. The duration of tube drainage is 4.5 against a 5.3. That is the thoracotomy, the multiportal, and this is uniportal. Between 4.5 days and a 5.3, there is a statistical difference. And there is a length of hospital stay between 6.8 days and the other one here I can't see because of, let me take this away. Yeah. Between 6.2 days uniportal and 6.7 days multiportal, there is a statistical difference. And also overall morbidity between 12% and 13.7%, there is a statistical difference. I went back to our publication in 2010, where we reported our results of VATS lobectomy. And I found the following, that our chest drain dwell time was only 2 days. So you compare the 4.5, this one, compare it to this one. And then the length of hospital stay is 6.2 days. You compare it to ours, which was 4 days. So if you compare Uniportal to our results, which were published 2010, you will see that Uniportal is retarded, completely retarded. I don't know. You tell me.
Prof. Khalid, I think we are overrunning the time a little bit.
Okay.
So you might have to come.
Shall I stop here?
As quickly as possible, and we would love to have you show that media channel video as well. So do you want to take it right now or after completing the debate with Alan?
I think I will leave it at the end because it's not really connected to the Uniportal, multiportal.
This one, we will invite Alan in for his counter.
Fantastic.
So do you want to conclude quickly or?
I can stop. No, that's fine. I mean, the rest is probably evidence, and I was going to show 1 or 2 complications. For instance, I can show you this quickly.
Yes, please.
The complications of the port creation. We've spoken about the abuse of the mid space using the instruments. Sometimes you get this, which is what's known as a lung hernia, because of the bad closure of the port. And I lost the natural progression of my, here it is. And this ledge, this is also a common mistake where the registrar, when they close the port, they stitch everything together in one sort of layer. That's wrong. The stitching of the port will have to be in separate layers, and you shouldn't take with you the pericostal of the rib. Otherwise, you fix everything and the patients don't like it. It just rubs against their shoulder when they're walking, this bit, this ledge, I call it a ledge. And I think that's about it. So, there's one thing I was wanting you guys, okay, this is a malignant seedling of the ports. Unfortunately, it happens in all the ports at one time, and I think it's a hematogenous sort of phenomenon. The answer to that is to operate and take them all with wide margin. And if you can't close them very appropriately, call the plastic surgeons to do that for you. Can I ask you guys for a favor? Could you follow us, the Southampton reviews, on the Facebook? I'm going to put all my videos, which George is asking me to do, in that website. And hopefully part of this also talk in it. And there are other nicer stuffs, advanced and basic, for trainees and for postgraduates. So please, please, please follow us. Thank you for listening.
Thank you very much, Khalid. That is a very lucid and illustrative talks. I think I will invite Alan in for the counter to your debate. He's going to speak for Uniportal VATS. In the meantime, there have been a couple of questions from the audience. Do you always stand posterior to the patient? There's one question.
I do.
Okay. So
always.
Always posterior to the patient. And do you give the local anesthetic before you start the incision or at the time of closure?
I do. It's preemptive analgesia, also using dexamethasone, the same potion I mentioned earlier on. I infiltrate before I open up. In that particular patient, I didn't, because the anesthetist did a block. They did an extra pleural block before we start.
Okay, so it is before the incision and at the end of the procedure?
Yes, it's very important.
Okay.
Preemptive analgesia, local infiltration is extremely important before you start.
So thank you very much, Khalid. We'll be going over to Alan. And Alan, are you ready?
Yeah, I'm right here.
Okay,
ready to start.
Let's start.
Okay, Okay, let me share my screen with everybody. Let's see. There we go. Okay, so I'm very thankful for everybody being here. Thankful for organizers. It's been a great first talk, and I'm very grateful that Professor Amir has already given you the basics of that, so we don't need to cover that. So we can jump straight in and start talking about uniportal VATS. And uniportal VATS, today, it's not new anymore. Diego first started doing this in 2009, 2010, so it's actually 10-year anniversary. And I think most of you in the audience will have already heard all about uniportal VATS. Some of you might have even seen some of my slides, but nonetheless, it's a great place in this particular webinar to compare and contrast uniportal with multiportal with subxiphoid. So with that, let's just jump straight in. So let's see. These are my disclosures, well, nothing too relevant. And so Professor Amir was saying just now that he was questioning whether uniportal VATS is a natural evolution from conventional three-port VATS. And if you look at it chronologically, it is. It's come later. Is it of evolution in terms of natural progression and improvement of surgery? Well, I like to say it's a change, it's a modification. I like to call these new types of VATS, including subxiphoid VATS, next generation VATS. And as you can see, with everything in evolution, there's always natural selection. There's a demand for a certain type of evolution, and that pushes and drives change. And you'll see in a minute that certainly conventional VATS is good. I've been doing it since the late 1990s. But over the years, we've seen a need to make things slightly better for our patients. Patients respond well. And that's why today we arrived at things such as uniportal and subxiphoid VATS. So this is how I set up my theater for uniportal VATS, if we're talking about how to do it. So for an upper lobe, I always stand in front of the patient with my assistant on the same side looking at the monitor. If we're doing a lower lobe, I sometimes swap positions with my assistant. So it's a little bit more ergonomic. We're looking slightly downwards towards the lower lobe. And when I operate in Shanghai, as Professor Zhang Lei will show you in a minute, we sometimes adapt to use a single monitor. Sometimes in the many theaters, sometimes we only have a single monitor. And when we stand in front and behind the patient, we actually share the same monitor looking in the same axis. And that's also quite an economical way of doing things. In terms of the instruments, these are my personal preferences. I always use a 5 millimeter 30-degree scope. Some people say, oh, the resolution is not very good. That's complete fallacy. With the high definition video systems we have nowadays, 5 millimeter scope is great. Now, the good thing about using 5 millimeter, and you can use that with subxiphoid, you can use that with the multiport VATS, is that it actually causes less torquing in the intercostal space. You lever much less against the intercostal nerve, and you have much more flexibility looking around inside. I use a pair of long scissors. It's my favorite instrument to dissect along the adventitial planes. And as you'll see in the videos in a minute, a harmonic device is absolutely brilliant for very quick economical movements during a labectomy. Other than that, this diagram here is the actual set we use for surgery in Shanghai. This is the Shanghai Pulmonary Hospital set here. And a particular note, all you ever really need for a labectomy is all here. You don't need anything more fancy than this. This is very, very cheap. You need a nice sucker. That's always good for blunt dissection. You need a pair of lung retractors. And I think these are probably the most important instruments in the entire set. And you'll notice here what we call a snakehead clamp. This is very, very good for dissection underneath different pleural structures or hilar structures. Absolutely fantastic. Now with that, let's see how we arrived at uniportal. So this is how I usually do a three-port VATS. This is what we've been doing since the late 1990s. I do it slightly different from what Professor Amir showed you. I always stand in front of the patient. I angle the ports, the baseball diamond, slightly. We rotate it slightly in this direction. And this actually allows a much more ergonomic approach. And if you'll notice, this is similar to what McKenna uses as well. We arrived at this in Hong Kong, sort of independently from McKenna, but this is how we did it. Now from there, about 15 years ago, I decided, well, actually it's a bit more than 15 years ago now, we decided, well, we can do better than this. So the next evolution was to make the camera port and the posterior port smaller. So we changed to 3mm ports, but the overall strategy was exactly the same. And this was quite a nice, easy evolution. The assistant had an easy time doing this. And when we got used to that, we got rid of that posterior port altogether. And now suddenly you have 2 ports. You just need to operate with both hands in the anterior port. And from there, you can see it's also very easy to go to single port. You can see this really is the definition of evolution, step by step by step. Now, once you get used to working with 2 hands in the same port, you just move the camera up here, change the axis of your view, and you're there already. It's not that big a step. So just to reiterate, you go from 3 ports to 2 ports by putting your 2 instruments in the same port. Camera stays in the same place. You go from 2 ports to 1 port, then by moving the camera into the same port. Easy. Anybody can do it. The biggest step, I think, is this, going from 2 ports to 1 port. Because when you go from 3 ports to 2 ports, it's just a surgeon. It's you. You're an experienced surgeon. You can adapt. You can instrumentate quite easily. But when you put the camera into the single port, the main difference is it's the assistant who has a tough time, because the assistant is usually a trainee, a resident. He's not so experienced. He needs a bit more time to get used to the visualization, how to hold the camera. For you, it's easy. So the good thing about this evolution is every time you go to a single port, if you get into any trouble, you just need to backstep. If you have problems with single port, go back to a 2 port, no problem. If you still struggle with 2 ports, go back to a 3 port. And that's the beauty of evolution. Now, when you do this in evolution, you also have to revise your philosophy a little bit. I always see doing 3-port VATs like this. I'm eating at a table. It's a flat plane. So I'm sitting at a table looking across a dish. My left and right hands come in from the sides. So it's operating on a flat plane. Now, when you go to a single port, this is truly keyhole surgery. When I'm standing in front of that patient, that wound is a vertical slit. And this is my view of how I'm operating. And you'll notice, of course, my eyes are above the level of my hands. So I look down, the camera is put at the back of the wound, the instruments come in under the camera, and that's a good hand-eye coordination. It's ergonomic. It also means that in this vertical slit, it's essentially like a set of traffic lights. So for 90% of the operation, the camera is always in the red light position, and your left and right hands are in the yellow and green light position. So you have this top-down view, which is very ergonomic. It's even more ergonomic than 3-port VATs. Now, occasionally, if you need to, you can always switch around. Sometimes if I'm looking underneath the hilum, I can always ask my assistant to put the camera into the green light position, or even rarely into the yellow light position. So that's how you communicate with the assistant. You use the 30-degree camera to look around the hilar structures. You can go right round, as I'm sure most of you already know. And in terms of retraction, it's always a bimanual retraction. If you get into any trouble during VATs, it's usually because your left hand isn't doing what it should be. So what I mean is, see here, if we get a difficult angle, here's my single port. I'm trying to do this vessel. It's a bit difficult. All you need to do is shift around your left hand, move that lung back and forth, and you can find good angles, as you see in a minute, to pass your staplers across, to pass instruments across. Always use bimanual retraction. So with that in mind, let's go through a simple lobectomy. This is a very simple left upper lobe. So this is how we're going to do it. In fact, because I'm standing in front of the patients, this is how I actually see the entire operation. This is how you're going to see the videos. This is how I orientate my camera. So we're going to start with the pulmonary vein, because that's the first structure in the front of the chest. And you can see just using scissors and a harmonic device for dissection, it's very easy to open a pleura. Now you'll say, Alan, where's your left hand? I thought you said bimanual. Yes, it is bimanual. My left hand is over here off the screen. I'm retracting the lung myself, and you're using the left hand to give you the counter traction and displaying the angles. Not only that, because you're controlling yourself, you can see it, I'm loosening my left hand, allowing the lung to swing forwards a bit while I rotate the stapler. And it's so easy to pass a stapler across veins like this. It's using your left and right hands, coordinating between yourselves to give you the angles you need. And this is top-down view, very ergonomic. This right hand is coming exactly where my right hand comes in with relation to my eyes, and you can therefore staple a vein. Now, once that vein's gone, you work around the top of the hilum, and you can see here again, I'm using my left hand off screen to adjust the angles. You notice how very subtly I'm moving this lung back and forth just to give me the right amount of tension, not too much, not too little, just to expose the view. And when you use that 30-degree camera, you can see right round all the way to the back of the hilum. Easy, no problem at all. Okay, it is a top-down view, very ergonomic. So we're dissecting it. If you want to save money, absolutely. Here you go. You can use some of these Grena or Hemalock clips. You don't need to staple everything. And it's very easy to do. You can do all the branches of the left upper lobe there. Now I move this lung back towards the superior side, and we're going to do the fissure. Again, we're using a harmonic device, dissecting in the fissure. This is more or less what you do in open surgery, what you do in multi-port surgery. And again, you can see we can right round the back of the hilum. We already did these earlier branches of the artery from the other side, and now we're just coming from the other, from the lower side of the fissure, completing this circumnavigation of the hilum. Very, very easy. And again, I'm using my left hand to give just enough tension just to make this dissection quite easy. You can see you can do all the arteries that way. Once that's all done, I flip the lung upwards. I put my camera a bit further down, and I expose the bronchus. And again, you notice here, I'm using the right amount of tension. Just let this hilum swing forward a little bit, and that allows me to pass the anvil of the stapler around the bronchus, and we can staple off the bronchus. Again, a very nice ergonomic view. So we're just going to complete that by putting the lobe now into a specimen bag. Very easy. And let's skip forward. That's the wound. That's the actual wound. Not very big at all. Okay. We go back in and we can start doing the lymph nodes. Again, very easy. You can take the number 7 lymph node from the anterior approach, as I am doing in this case. You can do it from behind, no problem at all. You can release the pulmonary ligament, do all the inferior mediastinal lymph nodes, et cetera, and you can complete the operation. Now, that's a lobectomy, and that's just step 1. And if you want to move upwards with that, you can go on and do various segmentectomies. Again, it's the same thing. You can see here, this is that snakehead clamp I'm using here, very good for dissection, and you can do any segments using exactly the same technique as I showed you just now. So if this is not difficult enough for you, you can go for more complex resections. So you can do intrapericardial pneumonectomies, you can do sleeve resections of the upper lobe, you can do basically anything you can do with multi-port VATS, you can do with single-port VATS, because it's not that difficult, isn't it? I'm not a particularly brilliant surgeon. If I can do it, all of you guys can do it. It just takes a little bit of patience, and always rely on the fact that if you get into trouble, you can always go back to 2-port, you can always go back to 3-port, you can even convert to open if necessary. And once or twice a year, sometimes even I have to do that. So you can see very good views. The views are not a problem at all. So the one thing I would emphasize when you're doing single-port VATS is never expect to have happy patients simply because you're doing single-port surgery. In this day and age, we're living in the era of ERAS, okay? You must complement your surgery with anesthesia, analgesia, good nursing, proper nutrition, analgesia, and of course, good chest drainage. Of these things, I would emphasize, just like Professor Amir said just now, a good nerve blockade. I use a preemptive pre-incisional paravertebral block with just simple bupivacaine. That's all you need, because you want to preempt the pain, you preempt the presensitization of the nerves before you even make the first cut. And that will ensure that the amplification of the pain signals after surgery isn't there, and patients recover very, very quickly. Now, this is just my personal experience. It's not evidence. This is just my own personal experience over the years. When I was doing 3-port VATS, this is the typical recovery you get. I think you all have the sort of same thing. Drain in for 1 to 2 days, go home in 4 days. That's fine. When we moved to uniportal VATS, we noticed already, anecdotally, an immediate improvement. Patients going home quicker, mobilizing a lot quicker. But that's still not good enough. If you do uniportal VATS and you complement it with a bespoke ERAS program, this is what I'm doing day in, day out, every single week nowadays. So we got our patients going back to the ward, and immediately they start eating, they start mobilizing, we get a drain out, and patients go home after a lobectomy, a segmentectomy, even more after just, well, less than 48 hours. And this is not an exaggeration. If I don't have a prolonged air leak, this is exactly what happens to almost all of my patients now. Now, you'll say, this is not evidence. Can you show some evidence? Okay, fine. If you want evidence, here's some evidence. This is a paper you might have seen from last year, published in the Annals. And you can see these are just case series. These are a case series of uniportal anatomical lung resections. And by 2019, you're talking about literally thousands of cases around the world being done very safely with reasonable blood loss, reasonable conversion times, very, very low mortality, and very low morbidity. So if anything, this just goes to show that uniportal VATS can be safely done on every single continent on Earth. Anybody can do it. You can do it. This is just safety, though. What about the advantages? Should I convert to uniportal VATS? Now, if you asked me in 2016, when I wrote this paper, I would tell you no. At that time, we did a systematic review, and there was evidence in favor of uniportal VATS, not that strong. But flash forward to this year, and this is just brand new. This is a chapter I wrote for Mark Ferguson's book. Go and buy it. It's my favorite book. I'm trying to do an advertisement here. But we revised the systematic review. And yes, there is a randomized prospective study comparing multiport VATS to uniportal VATS. It didn't show any difference. But if you look across the whole spectrum of the literature available today, you'll see that the boxes in blue showing uniportal VATS has an advantage. There are many more blue boxes than there are red boxes, which showed multiport VATS might be better. And in particular, you will see that this column here in pain, almost very consistently, all the studies tend to say that you have less pain. Is that important? Well, maybe, maybe not. But still, overall on balance, compared to 2016, we're seeing an increasing volume of evidence saying that uniportal VATS is probably a little bit better. Now, is it better enough? Is it improvement enough for you to change your practice? Now, that's arguable. If you ask me, I'm already doing multiport VATS. Can I switch to uniportal VATS? I would say on balance from the evidence, yes, it's quite safe. A lot of people have already done it. But if you're saying I'm doing multiport VATS, should I switch to uniportal VATS? I would still say even today, maybe not. I mean, there's not a lot of pressure for you to do it. There is, as I said, some benefits to doing uniportal VATS, but the absolute benefits, for example, in pain score, is on an absolute scale, not that big. So maybe there's not a huge impetus for you to definitely change to uniportal VATS. However, I think that's also missing the argument. Everybody is always thinking, oh, I'm already doing 3-port VATS. Should I move to uniportal VATS? And maybe not. But here's another way of thinking about it. If you're a young surgeon out there and you could do either uniportal VATS or multiportal VATS, what's the evidence telling you that putting 2 extra wounds is any better than just doing it through a single wound? If there's no advantage in putting 2 extra wounds and you can safely do a single port VATS, why put 2 extra wounds in that patient? And if you use that logic, then yeah, maybe if you're starting out, definitely consider uniportal VATS. There's no reason for people definitely to put in 2 extra wounds if you don't need it. So here are my final thoughts. I think the transition from 3-port VATS to single-port VATS is evolutionary. And that has implications because it means it's actually quite easy to do. And it also means that you can always fall back to 3 ports if necessary. When you transition from multi-port VATS to single-port VATS, the challenge isn't in you yourself. You're an experienced surgeon. You can adapt. Usually the difficulty is in your assistant. And we always say if your resident is your assistant, he's a resistance or she's a resistant. And he or she is the person you need to train the most as you transition. The benefits from uniportal VATS, maybe they're there, but they really only come to the fore if you integrate it with a bespoke ERAS pathway. I cannot emphasize that enough. You won't see the maximum benefit from uniportal VATS unless you put in the ERAS. So Professor Amir was showing you that paper from Australia showing not much benefit from uniportal VATS. And that's because in the early experience, they didn't adapt their clinical pathway to take advantage of the uniportal VATS strategy. And last but not least, I think if you're thinking about uniportal VATS, I can assure you today that the safety of this approach is well established. The advantages, they're not that marked right now, but the evidence is growing each day. Every week, every month, we're getting new papers on this, and the advantages, if you wait for long enough, you will see them emerging. So that brings me to the end of my talk. Thank you very much for your attention.
Thank you, Alan. That is a wonderful talk, really lucid. And thank you for not taking too partisan a view about uniportal. I think Khalid and me have just sighed a relief, sigh of relief. You're not dynamic. And also, if you notice, for the audience benefit, both the surgeons have emphasized the importance of ERAS and giving adequate analgesia before and after the surgery. That is the key to a good recovery from whatever VATS you're doing. We have one question from the audience. Alan, it's basically directed at you. So is there a transition point? Do you need to do multiportal before you step into uniportal? Or do you suggest doing a certain amount of basic surgeries or basic multiportal surgeries before progressing to do a uniportal?
That's a great question. You remember back in the old days, people were saying, oh, should you do thoracotomy before you go to VATS? I think we've kind of resolved that argument now. And I think most of us think that maybe you can start doing multiport VATS straight off. And I think it's the same thing with uniportal VATS. The key to it is not you yourself. It's your entire hospital, your unit, whether the rest of the unit is able to back you up. Now, if your unit is very experienced with advanced thoracic surgery, if the rest of your unit already has some experience with minimally invasive surgery, there's no reason why not to go straight into uniportal VATS. But if your unit is really uncomfortable with even just handling camera, how to convert in case of bleeding, then maybe, yeah, okay, you take it step by step and maybe start with something simpler like 2 ports or 3 ports before going into portal. So I don't think there's a one-size-fits-all answer. It really depends on the people around you as well as you yourself.
So what you're saying is, if you have an experienced setup, probably you could start off with uniportal. And if you are set up starting off, then probably you might progress from multiportal to uniportal. Yeah. So you said, and both you and Khalid have clearly said that horses for courses. So if you find a bigger tumor or more difficult one, put more ports or even open. So I'm someone who's actually trying to progress to uniportal. Do you sometimes miss using a left hand to hold a structure rather than push when you do it with uniportal?
No, as I showed you in the video just now, my left hand is very, very active. You have 1 port, but the key to success, I think, in uniportal VATS is good use of that left hand. I've been teaching uniportal VATS around the world, as you know, and when we see people get into trouble, it's usually because their left hand is static. It's not doing anything. And you're trying to do everything with your right hand, and it doesn't work. It's always a bimanual procedure, and Diego will say the same thing. It's bimanual. Make sure your left hand is actively involved. Even if it's off screen, we're always constantly titrating the tension we're putting on.
Excellent answer. So the key is the use of the left hand, which is what we try to drive into everyone, including the resistance, as Alan said. A quick question about the oncological benefits. Is there an oncological equivalence vis-a-vis? Is there any evidence supporting uniportal versus multiportal in terms of lymph node dissection and outcomes?
Excellent question. I think we can break that down into 2 parts. In terms of the adequacy of resection, in terms of R0 resections and the number of lymph nodes are taken out, I think there's enough evidence now to show equivalency between that and multiportal VATS. What we don't have are the long-term survival figures. We've got a few case series that show equivalency, but I don't think you have enough volume yet. But looking back at the multiport VATS experience, it took almost 20 years of multiport VATS before we actually achieved that kind of survival data. So give it some time, and I'm sure we'll show it with uniportal VATS as well.
Okay, so we'll have to wait a little bit longer to get long-term outcomes, is what you're seeing. Another question is, I noticed that in your first video, this question has come from the audience actually. In the first video, you were using long open instruments, I suspect, and in the later videos, you were using specialized. So can you do this uniportal with open instruments, the long ones, Roberts, for instance, which Khalid is using?
Yeah, absolutely. Well done to you guys who spotted that. So the early videos when I was doing the left portal, those are really from my early experience. That was about a year or two into uniportal thymectomy. So I was using open instruments, but then after going to Shanghai, where Professor Zhang Lei is from, we've used a lot more of the Shanghai instruments, and they are absolutely brilliant. If you want to buy them, ask Professor Zhang Lei. He'll probably put you through. They are absolutely cheap, brilliant, reliable.
Okay, so I guess that brings us to the end of your talk and the questions which come from the audience. Thank you very much, Alan. And Khalid, I'm going to hold you back for another video at the end. So thanks, Alan. I think we'll be moving now to Yang, and he's going to show us Subxiphoid. Is Yang ready?
Hello?
Hello. Hi, Jiang. How are you?
I'm fine. Nice to meet you. I'm in Shanghai. Yeah. Today I will give a speech about the Subxiphoid operation.
Yes.
Bye-bye.
You will have to share your screen now, I think.
Yeah.
Yes.
My topic is Subxiphoid uniportal VATS for lung cancer resection. Well, let's begin. First, I'd like to introduce myself. I'm from Shanghai Primary Hospital. My name is Jiang Lei. Shanghai Primary Hospital is specialized in lung disease, and each year we performed more than 70,000 cases of lung operation. I think the number is the world largest number. So we have a lot of experience about lung surgery and some complex operation and Subxiphoid operation. Today, I'd like to introduce our experience about Subxiphoid uniportal VATS to treat lung cancer. As you know, the uniportal VATS through intercoastal space has already been accepted alternative to traditional three-portal VATS.
I think he's got away.
Okay, let's begin. But there is a problem. The uniportal VATS through intercoastal space. Some patients suffered from the long-term post-operative incision pain due to damage of the intercostal nerve. So under these circumstances, we designed the uniportal Subxiphoid approach to treat lung cancer. We named it SWAT, Subxiphoid single port. According to the literature, in 2014, Professor C.C. Liu from Taiwan reported the first case of Subxiphoid uniportal VATS left upper labectomy. This paper published in journal ETCVS. At that time, Shanghai Primary Hospital began this work and designed our special instrument technique to perform Subxiphoid uniportal VATS operation. According to Subxiphoid incision, there is some advantage of this incision. The main advantage is there is no long-term post-operative pain because this incision do not damage the intercostal nerve. Another advantage is one incision, we can treat bilateral disease, lung disease, and also we can remove mediastinal tumor, such as thymectomy. Through Subxiphoid incision, there is a better view for cardiophrenic angle. If there is addition, it's a better incision approach to dissect the addition, surround the cardiophrenic angle and the addition on the diaphragm. And in our experience, there is a very, very low subcutaneous emphysema according to the subsidiary incision. I think in my experience, there is nearly no patient underwent subsidiary VATS operation will experience subcutaneous emphysema. But the disadvantage of this incision is also very obvious. Until now, this approach is also a technique demanding operation. Very, very few surgeons take this approach to treat lung disease, especially for the lesion located in the neural in the posterior segment. It's more difficult to approach this incision compared with the intercostal space incision. And during operation, we should compress the heart. So for that side disease, it's difficult to perform lymph node dissection. And subsidiary approach should have a long-term learning curve than intercostal VATS incision. And another disadvantage of this approach is it's more expensive because we need a special instrument. And sometimes when we use intercostal space, we can use finger to palpate the lesion. But subsidiary approach, you can't use the finger to palpate the lesion. It's too far from the incision to the lesion. So you can't reach the lesion through subsidiary approach. And until now, we only perform some easy case through subsidiary approach. We still cannot perform difficult cases such as Labectomy, coronal reconstruction through the subsidiary approach. In our experience, we only choose early stage lung cancer without lymph node involvement through subsidiary approach. Commonly, this disease we will perform a thymectomy, but in highly selected patients with stage 2 or 3 disease, subsidiary irreparable VATS labectomy or pneumonectomy is also a choice. But you should take care. You should only choose highly selected patients, suitable patients, not every patient. The contraindication for subsidiary approach include the following. The patient with diffuse disease is not suitable for subsidiary approach. And the obese patient, the BMI more than 30 is also unsuitable for subsidiary approach because there is a lot of fat tissue in the mediastinum, in the cardiophrenic nerve, cardiophrenic angle, so it will interfere with your operation. And the patient with cardiac disease, such as cardiomegaly, arrhythmia, or coronary artery stent, is also unsuitable for cardiac subsidiary approach. Now I will introduce our technique. Today, our topic is about the technique of subsidiary approach. The following, I will introduce some how to perform subsidiary irreparable VATS operation. About the anesthesia, we also use general anesthesia with one lung ventilation. But some patients nowadays, we also carry out some non-intubated anesthesia. Like this, the patient will put on a mask and give some medicine intravenously, and we perform subsidiary irreparable VATS segmentectomy, Labectomy, but you should take care. We only choose that side disease. And about the position of the patient was placed in the natural decupitous position with the body inclined about 10 degrees to facilitate the placement of the instrument, placement of the thoracoscopy. And this picture shows the incision. We like to perform a vertical incision along the midline. And this picture shows the operation. Commonly, assistant stand on the back side of the patient, and the surgeon stand in the front of the patient. We perform a 4 centimeter long longitudinal incision, and I like to remove the subsequent process completely. And after placement of the I like to remove the fat tissue along the path from the thoracic cavity. Now I like to show a short video. First, we made a longitudinal incision and remove the subsequent process completely. The incision is along the midline. We do not cut the muscle. We use blunt dissection with the finger, dissect behind the sternum, and create a tunnel between the anterior mediastinum and the thoracic cavity. Now, under the incision is the diaphragm. We use the suction to press the diaphragm to facilitate the exposure, and use a special electrocautery to open the pleural cavity. After this procedure, I like to remove the fat tissue along the cardiophrenic angle. This is very important. After remove the fat tissue, we begin the operation. Because the fat tissue will interfere with your procedure, you should remove completely. I should mention that this operation is a cooperation between surgeon and the assistant. So the assistant is very, very important. Without the cooperation with the assistant, you can't perform subsequent operation by yourself. Normally, the assistant stands at the backside of the patient, but for inexperienced assistant, he still stands in the same side of the operation, in the same side of the surgeon. So you should need 2 assistants to help you, like this picture. And we also designed a special instrument for subsequent approach. We have patent for our instrument. This instrument is longer than conventional instrument. It's longer. It's about 42 centimeter long. And the tip is special designed for subsequent approach. This instrument, the sternal lift, and some clamps, some right angle clamps, the suction, all of these are special designed for subsequent operation. This picture shows I operate in Egypt through subsequent approach to perform a right upper labectomy for a lung cancer patient. Now I'd like to show some video for how to perform lymph node dissection. Through subsequent approach, lymph node dissection is very difficult, especially on the left side. But on the right side, it's possible. On the right side, we perform station 4 lymph node dissection. And first, we dissect the azygous vein and lift the azygous vein up. And dissect the lymph node behind the azygous vein. You can see we use a suction to lift the azygous vein. And I also like to use ligature to dissect. During the procedure, we should use suction to press the superior vena cava to exposure the lymph node behind the superior vena cava with station 2 lymph nodes. Now, when we choose patients, I like to choose some thin patients, not obese patients, because obese patients, there are a lot of fat tissue, and the heart is large. The superior vena cava is very high, so exposure is very poor. I prefer use ligature to dissect the lymph node. You can see after lymph node dissection, the lymph node is completely removed in the upper mediastinum. Next, I will show on the left side lymph node dissection. But on the left side, the lymph node dissection is very, very difficult. And I like to choose patients without lymph node involvement because if we want to dissect the lymph node on the left side, sometimes it's impossible because you should press the heart and cause very severe arrhythmia and hypertension. So it's unsafe. Now I dissect the station 4 lymph node. This patient is a good patient. We can completely remove the station 4 lymph node after high encircle the pulmonary artery with a suture. Pull the pulmonary artery forward to exposure the station 4 lymph nodes. Now I will introduce segmentectomy through subdivided approach. Our subdivided segmentectomy is focused on bronchus. We named it bronchus-centered segmentectomy. The key point is to dissect the segmental bronchus sufficiently and distally, and the accompanying artery were divided with the segmental bronchus. We also designed a method to determine the intersegmental plane. We call it open insufflation. And there is no need when we perform segmentectomy to dissect intersegmental vein. And we divide the intersegmental vein with staple. Now I'd like to introduce the technique to determine the intersegmental vein. We call it open insufflation. This is the pattern of open insufflation. This video shows the S3 segmentectomy. First, we dissect the vein of S3 using electrocautery. This electrocautery is designed for subdivided approach. It's a curved electrocautery. And I like use silk suture to ligate the vein and cut with ligature. There is 2 veins to the S3 segment. After divide the vein, we can dissect the artery to the station 3. And we also use silk suture to ligate the artery and divide with ligature. Then we dissect the bronchus. Encircle the bronchus with a silk suture and ligate proximally. Cut open the bronchus distally and insert a small catheter. Insufflate the segment, the targeted segment, until the segment fully expanded, and determine the intersegmental plane. The key point is the opening of the bronchus is not closed, it's an open incision. So the pressure in the bronchus is not very high. The air will not enter the bronchus, other bronchus, only in the targeted bronchus. Then we dissect the bronchus. And lift the bronchus, use staple to cut along the intersegmental plane. Now we also perform some non-intubated subsequent VATS segmentectomy. I would like to show a video of that upper S1 segmentectomy through subsequent approach under non-intubated anesthesia. After placement of the incision, first we dissect the vein and the artery of S1 segment. This is the S1 segment vein. For this small branch, small vessel, I can use silk suture to ligate the small vessel. Now I dissect the artery to the S1 segment. You should take care to preserve the recurrent artery to the S3 segment. Then I ligate it. And cut it with ligature distally. During the procedure, you can see the diaphragm of the patient move up and down because the patient is have spontaneous respiration. Then we dissect the bronchus. This right angle clamp is specially designed for segmentectomy. It's very sharp and small. After dissect the bronchus, we cut open distally and insert a small catheter. Insufflate the S1 segment. After the S1 segment completely expand, we divide the bronchus with a tri-staple. Tri-staple is very useful during the procedure because the angle is very poor. The curved tip facilitates the placement of the staple. After divide the bronchus, you can expose some small vessel drainage the S1 segment. It's a small vein. And we dissect along this segmental bronchus distally. The purpose is we should prevent divide into segmental vein at the hilum of the segment. So we dissect using electrocautery along the intersegmental bronchus. In order to have a good expansion of the remaining segment after the operation, At last, we divide the intersegmental plane, use staple. But our technique is different. We do not continuously use staple to cut the intersegmental plane. Between each staple, we should divide it. We call it separate staple to facilitate the expansion of the remaining line. Separated staple. You can see after we place the first staple, we cut the staple line open and place the second staple. So the staple line is separated, not continuous. At last, I would like to show some difficulties through the subdivisional approach when we treat some advanced stage lung cancer. But we only should take care. We should take care. Only select some highly selective case, some suitable case. Not everyone is suitable for subdivisional approach. This video shows the subdivisional approach to treat the left lung disease, central lung cancer. We performed the Lympectomy through subdivisional approach. First, we remove the fat tissue in the anterior mediastinum. There is a diffused adhesion in this patient. Before the operation, we should dissect the adhesion. After the section of the adhesion, now we dissect the upper vein and encircled with a thick suture, the pulmonary artery, we use a special instrument to enlarge the tunnel behind the artery. Then we cut the artery with tri-staple. You can see during the operation, we press the heart, sometimes severely, and the patient has a normal cardiac function. First, we divide the artery, then we divide the upper pulmonary vein. This is the upper pulmonary vein. At last, we expose the inferior pulmonary vein. You can see the exposure is very difficult. We use this suction to press the heart. The exposure is very difficult. During the operation, you should take care not to open the pericardium, because if you damage the pericardium, it's very easy to injure the heart. So you should keep the pericardium intact. At last, we dissect the station 7 lymph node, lift the bronchus. When you expose the station lymph node, you should press the heart with suction severely. So I think this procedure is sometimes is dangerous. So only highly selective patients are suitable for this approach. For the right main bronchus, I like to use a black staple to divide it. This is station 7 lymph node. The bronchus was divided with a black staple. The black staple is very strong and safe. After resect the lung, we place the lung in a plastic bag and pour it out through the incision. There is some remaining addition in the posterior mediastinum. Place the lung in a plastic bag and pour it out. Subsequent approach can remove larger specimen because there is no restriction by the rib, so the incision can enlarge more significantly.
Dr. Jiang, I think we are running out of time. Can we conclude the presentation?
Okay, nearly finished my operation. At last, I give some comment about my topic.
Yes.
The incision is a feasible approach for pulmonary segmentectomy in highly selected patients, but it's still a demanding procedure. Until now, it's only performed by some experienced surgeon. So the operation is dependent on meticulous cooperation between surgeon, anesthetist, and nurse. If you have interest, you can refer to my book, The Video Assisted Thoracic Surgery. It's the first book about this topic. Thank you very much. This is all the surgeon and the fellow in our hospital, thoracic department. Thank you.
Thank you, Jiang. That was a wonderful demonstration and wonderful videos. There are a couple of questions from the audience. One was, do you always inflate the lung through the bronchus before doing a segmentectomy? Do you place a catheter in the bronchus before doing segmentectomy?
Sometimes we will decide the intersegmental plane, we place the catheter open insufflation to determine the intersegmental plane. But not every case. Sometimes we can also use the open and insufflation and desufflation method to determine the intersegmental plane. Not every case. There are several methods to determine the intersegmental plane. We can choose each patient what method to determine.
So another question is, do you find that in some segmentectomies, the lung does not expand or there is more air leak?
Expand, why the lung can't expand when we perform open simulation?
No, the residual lung, the remaining lung does not expand sometimes.
When we perform open insufflation, the lung not expand?
Yes.
Commonly, but this method is not suitable for every case. When we perform Segmentectomy and basal segmentectomy, this method you can't inflate the lung sufficiently. But it's suitable for some small segments, such as anterior segment, epical segment, posterior segment. And when we insufflate the segment, sometimes the segment will not completely expand. And under this situation, you can determine the intersegment plane through some anatomical marker. Use the intersegmental vein, through the bronchus to determine the line between the segments.
Okay. Thank you, Dr. Jiang, for a really excellent presentation and videos and answering all our queries. I think we will move on now to our next speaker, Professor Rajendra Parishad, who's going to speak about VATS and RATS thymectomy. Thank you, Jiang.
Thank you, George. Nice to meet you.
Pleasure.
Okay, thank you, Dr. George. You can see, can you see my screen?
Yes, yes, it's visible.
Okay. All right. So I'll start my talk. You have just heard very wonderful talks by three very, very experienced people. And I think when we see some of these advertisements, in which people are shown doing bungee jumping and other kind of stuff, there is a disclaimer that don't try it on your own. And I think that kind of a disclaimer should be there with people like Dr. Amir, Dr. Sihoy, and Dr. Jiang Li. What they have been able to achieve is after long experience, and I am not so experienced a person, and my talk is going to be a little basic. And okay, so the topic given to me is to talk about minimal invasive approach in thymic malignancies, and particularly VATS and RATS. So I will try and give you some basic idea about thymic malignancies, and then go on to give you the evidence that is there, and if time permits, show you some videos. So thymic epithelial tumors are a heterogeneous group of rare tumors, and the worldwide incidence is about 1.3 to 3.3 per million. Most of these are thymomas. The next are the thymic carcinoma, and then you have these neuroendocrine tumors. If you actually see the list of tumors that are classified under this, it's pretty long, but these are the three major things. Fourth, they usually present in fourth and fifth decades, and one of the important paraneoplastic syndrome that they present with is myasthenia gravis, and that is seen to be there associated in about 30 to 50% of the cases. There are other autoimmune disorders which are associated with it, such as red cell aplasia and Goods syndrome, but and many more. But one must be aware of myasthenia gravis, and you should actively look for it. Our experience mostly is thymomas with myasthenia gravis. And this is a WHO classification of histopathological subtypes. And if you see that the predominantly cortical thymoma or B1 and B2 are associated more with the myasthenia gravis. As you go down the list, the invasiveness of the tumor increases, and of course, the carcinomas being most invasive. And again, as you see, the long-term survival, which is seen in thymomas in terms of 15 to 20 years, they are not very, very fast-growing tumors. It again goes down as you move from type A to type C. Now, with respect to staging, there are multiple staging systems, and Masaoka-Koga system is the most accepted system of staging, and that has, been the predominant staging system over years and years. And these are the sub-classifications of Masaoka-Koga. And as you can see, the 5-year and 20 years survivals again are related to the stage. So they kind of prognosticate and they tell you. Now, as you must have noticed that this staging system does not take into account lymph nodes as is there with most of the malignancies. The lymph nodes are an important part of the staging systems. So therefore, this, Thymic group came into being, and they kind of collected the data of about 10,000 patients, and based on that, they decided to propose a HACC-TNM classification. It's a combined classification with Thymic and HACC. And this is the classification. Now, there are some differences, Masaoka-Koga, and it also takes into account the nodal involvement in thymic malignancies. And the main purpose of this classification is that it, once you take nodes into account, then it can help you to prognosticate. And this is what is now being evaluated, that whether this will stand the test of time. Now, I am not going to details of it again because of lack of time, but these are the lymph node stations that Thymic had described. The anterior ones are depicted by the blue and the deep ones are depicted by the purple. There's N1 and N2 nodes. So if you see, these are the lymph nodes which are depicted as N1, and the purple ones are considered the deep nodes, and along the internal mammary arteries and the cervical lymph nodes, they all come into the, there are different sub-classification, but generally, if you look at this picture, the nodes which are around the thymus gland, they qualify as N1 nodes, and the deeper nodes are qualified as N2 nodes. For some strange reason, this is not moving with, okay. And this is how the Masaoka-Koga and the International Thymic Malignancy Interest Group stagings compare. And these are the survival rates associated with them. And as you can see that as you go down the stage, the survival rates also dip down. And one of the major differences that was noticed was between stage 4A and 4B, which effectively means pleural metastasis or pericardial deposits that are seen in thymomas versus the nodal or hematogenous. And that is kind of what prompted them to take into account the nodes. Now we'll come to the management part of it. So preoperative evaluation is very important as in any other case. And you must look for prior history of neck irradiation or thoracointestinal surgery, because all these things can impact your surgical performance. And you should look for particularly myasthenia gravis and other autoimmune disorders. The imaging is the, the backbone of the evaluation of this group of patients. And you may see thymomas in a chest X-ray if they are large like this here, but CECT continues to be the gold standard. MRI is selectively done in patients who are not, suitable to get a contrast, or who are allergic to that, or when you want to differentiate a hyperplasia from the thymoma. So MR helps to do that. FDG PET is usually not used unless you are, in a carcinoma or a recurrent tumor situation, but it's usually not used. I'll now show you some of the examples of CT imaging. Now, the thymomas can be like this, very well encapsulated tumors, or very large tumors with calcification, which can be seen in up to 10 to 40% of the patients. Or, as you can see here, they can be invasive thymus. Now, this particular tumor is very much amenable to upfront surgery without doing much. This one may also be operable, but invasive thymomas like this are not suitable for upfront surgery, and they will need neoadjuvant treatment. Here, what you can see are the pleural metastasis from the thymoma. So you have to look for all these things when you are doing these imagings. Now, what are the considerations in myasthenia gravis patients with thymoma? That you have to have a multidisciplinary evaluation along with the neurologist, anesthetist, pulmonologist, and surgeon. And you must evaluate for myasthenia with the necessary antibodies and neurological examination. These patients must be stabilized well before they are taken up for surgery. Otherwise, you can have crisis in the post-op period, and that is quite disastrous. So there should be no myasthenic crisis. Symptom must be under control. With regard to preoperative biopsy, there are no definite guidelines. Most people would say that if the tumor is resectable in a typical setting with typical imaging, one does not want to do a biopsy. However, if it's an advanced lesion or invasive lesion, it's unresectable, or there is a diagnostic doubt, then you would want to do a biopsy. And NCCN and ESMO recommend pre-op biopsy for locally advanced unresectable tumors, or when the diagnosis is in doubt. The treatment depends upon the stage of presentation. The surgery continues to be the mainstay of the treatment. Adjuvant therapy in form of radiotherapy or chemoradiotherapy based on the stage. In unresectable lesion, one would like to give induction chemotherapy. There is some debate about whether induction or chemotherapy or chemoradiotherapy should be used, but this is not settled yet. And if you're going to palliate an invasive and unresectable tumor, then of course, chemoradiotherapy is what comes. Now, our main thrust of talk is going to be surgery and how to approach it, and through minimal invasive and mainly VATS and RATs. So it is indicated in resectable tumors, which would mean Massaoka-Koga stage 1, 2, or ethnic TNM stage 1, 2, and 3A. These patients will go for upfront surgery. And what do? You do a radical thymectomy, which means remove the tumor, the whole thymus gland, and perithymic fat. You can use open or minimal access technique based on your expertise, although we'll talk about the evidence later. If surgical principles are respected, then you can use either of the two. No contraindications to either with neighboring organ invasions. But if you have something like a lung or a pericardium, yes, you can take it out. But if you have a major vascular structure involved, then you may be better off doing an open surgery. By and large, these studies have restricted themselves to less than 5 centimeter tumor with respect to minimal invasive surgery. However, larger tumors have been operated, and we have also had that experience. What about thymomectomy? Now, you can actually have a full class on thymomectomy, a full session on thymomectomy, but generally speaking, in nutshell, it means removal of tumor, leaving residual thymic tissue and perithymic fat. It's not routinely recommended. There are studies, JART1, JART2, and other studies which have looked at it with the angle of preserving thymus because it has a role in T lymphocyte production, and it has been seen that patients who needed autologous bone marrow transplant, and if they have had their thymus removed, then this was not possible. So that is how this whole debate started. But by and large, as of today, the consensus is that it can be used in clinical stage 1, elderly, non-myasthenic patients. In myasthenia, you can't do it. And lateralized tumors which are away from phrenic nerve or the brachiocephalic. This is the nutshell about it. And this is a proposed management strategy. This diagram I have taken from a position paper by Italian collaborative group for thymic malignancy, and this was published in 2018. So as you can see, upfront surgery thymoma, if you have achieved a R0 resection, which is the aim of treatment, this is the most important factor which will determine the outcome. It kind of supersedes the lymph node involvement and involvement of having pleural mets and other things. If you can do an en bloc R0 resection, that supersedes all other prognostic factors as of today. So in 1 to 2A, you can, if you have done R0, you can straight away go follow up. If it is 2B, then there is doubt. Some people would give radiotherapy, some people may not. For 3, definitely radiotherapy. And if there is R1 resection, definitely you have to do adjuvant radiotherapy in stage 1 to 2. In 3, radiotherapy followed by chemotherapy. So this is a proposed management protocol, but that is not the aim of our talk today. Well, and with regard to lymph node, a Kondo's review of 1,320 thymic epithelial tumors is what basically led ITMIC to recommend nodal dissections. And what they suggested was that nodal and metastatic stage, which is M1 is basically pleural and pericardial deposits, and M2 the deposits outside this area. And they felt that N and M stage influences the outcome more than the T stage. And thymic carcinomas, M2 is hematogenous and lymphogenous spread. And thymic carcinomas have higher nodal mets than the thymomas. And there was a significant 5-year survival difference in 4A, which basically is pleural pericardial, and 4B, which is lymphatic and hematogenous mets. And therefore, the recommendation now is to do lymph node dissection to help prognosticate. And standardized lymph node maps have been generated, which I've shown you earlier. And it's recommended that for anterior groups, if there is no mediastinal infiltration, that means early disease, you can just restrict yourself to anterior N1 group. The blue ones and the purple ones you will go for if it is an advanced disease. Now, this is how the surgical evolution has happened from 1896 to 1912. Thymectomies were usually done for respiratory distress in children, and for enlarged thymus, etc., mostly using cervical incision. And then subsequently, Gehr removed a hypertrophic thymus with myasthenia gravis symptoms, and they were relieved post-surgery. And Blalock removed a tumor from the thymus in a patient of 21 years old, and the patient improved gradually. So he indicated that there may be a relation between thymus and myasthenia gravis. And these were all done through median sternotomies. And then subsequently, the paradigm shift happened with Mesoka and Mondin, who generated this concept of extended thymectomy. And Sugarbaker was the one who started VATS, and then Roosevelt in St. Luke, Roosevelt did the first RATS procedure. So these are the open approaches: median sternotomy or cervical thymectomy, although cervical some people consider minimal invasive, and the minimal invasive being VATS and robotic. Now VATS can be multiportal, unilateral, or hybrid, unilateral with subxiphoid, or subxiphoid single port, as has been shown by Dr. Jiang Li. And same is true of robotic, whether you do a multiportal or you do a subxiphoid. But broadly, we'll talk about that in our videos shortly. So these are the principles. Just to reiterate again: radical thymectomy, no touch and minimal handling of the tumor, and block resection of the surrounding organs. So say, for example, if this picture that you see, part of the lung is attached to this, you should not try to separate it out and take it along with the tumor. Or if, for example, here is the phrenic nerve which is going through the tumor, so in this case, you have to sacrifice it. If patients have myasthenia gravis, one does make an effort to try and if you can find a plane and separate it out, because phrenic nerve resection can cause a lot of problems in the myasthenic patients. However, if it can't be spared, then you must sacrifice it. Remember that you must convert if principles of surgery, as indicated above, cannot be achieved. No, this is how the surgery has evolved. These are some of pictures from our own patients, big sternotomy, partial sternotomy. And these are not necessarily all thymoma patients. I've just given you the pictures. This particular patient, thymoma, large thymoma, resected, one of our patients in our early experience, resected through VATS approach, but then we had to give an incision to take it out. And then these are now patients where you completed the procedure. This is the lateral approach. And of course, the robotic is the next. Now, so this shows the lateral approach where you put these ports like this. Patient is elevated on a sandbag and the arm should be down below so that your instruments don't. And this is our currently favored approach where we put a subsified port, and then depending if the tumor is on one side, then we put the lateral ports there. This is the other way you can do it, where you can put the subsified camera remains here all the time, and then you have these two ports. We have had some issue with that, and I did show it to Dr. Khalid when he was here with us last year, that the ports tend to impinge on the heart and sometimes cause a bit of a problem, particularly if you have a short and stocky patient. So Dr. Jayangli also did mention that through subsified there can be some pressure on the heart, excess pressure on the heart. So we try to put our camera port here and then switch it between this and this port as the dissection proceeds. But to begin with, I think this is the best way to do because it's quite ergonomic and you can do your job. The advantage of subsified incision is that you can take larger tumors out and through this incision, and then you don't need to give the incision that I showed you earlier. Now for robotics also, more or less it is same. This is picture that I'm showing from Dr. Folio's paper, and this is how we also kind of, the only thing is in here you are also putting an additional port through which your assistant helps you. So instead of 3, you end up having 4 ports in a robotic approach. And this is our own patient. Now you can see the patient is elevated, arm should be well down so that there is sufficient distance for your instruments to go down and up. Otherwise, they can clash with the arm. And here you can see the robotic ports having been put, and this is the port which the assistant uses. And this is the picture you see when you enter from the right side, the SVC, the phrenic, and this is the region of the thymus. And this is how you see it from the left side, the arch of the aorta, and this is the phrenic, and the vagus will be somewhere here. And you can see some nodes shining through here. Internal mammary veins, so you could go from internal mammary to internal mammary, and from both the upper horns have to be taken, and the up till the costophrenic angle. So this is the kind of the resection that is expected to be done. Though these pictures have been described more for myasthenic patients, but even in thymomas, it is better to take. So after you have resected the specimen, they should be put on these boards so that the pathologist is properly. There is a lot of importance of this because otherwise this specimen you send and they can't figure out what is what. So this is, that's not a thymoma, but you see all of the pericardial fat has to be taken along. These are the aortopulmonary fat. And this is a patient with a large thymoma with all this fat taken, and you should place it on this board and you can see the lung attached. This is the picture of the same patient and I'll show you a video of this patient. So it is important to orient this for the pathologist so that they can properly. Now, to begin with, this is a small thymoma, and this very short video of about a minute or so will give you an idea about what to do. So you start along with the phrenic nerve, and you can actually see here the lymph nodes. Now, we have done about more than 50 thymomas through VATS, and all of these have been associated with myasthenia gravis. And we have removed these lymph nodes, but we have yet to see any lymph node turning out to be positive. So then, you carry the incision to the opposite side, and then you, kind of dissect the gland of the pericardium and try to stay in the loose areolar tissue plane. In a small thymoma, it's not so much of a problem. And you must take, as you can see, all the nodes have been taken. Then you go identify the brachiocephalic, go for the horns. This is a sped up video just for the, and just to give you an idea. So this is the left thymic horn, which is being dissected. And usually these horns are, enclosed in a small capsule. Once you give a nick, then they kind of tend to pop out. And here you can see there are sometimes vessels there, and you should take. But then you move along the brachiocephalic vein to the other side, and then you identify these thymic veins, and then you clip them, and you can divide them. And then comes your next, the opposite side horn, and all this has to be taken. Once you've taken that down, then you continue your dissection, take it off the pericardium, go right up to the opposite pleura, and one should try to identify the opposite phrenic nerve, particularly in cases of myasthenia gravis. If you don't have myasthenia, still you should do a complete dissection, but I think one would not go crazy about looking at the opposite nerve. And then you bag it, and then you take it out. So this was just to give you a brief idea about how the, now let's see this video where you have this biggish tumor and you have this lung which is attached to it. So first thing we need to do is, we don't want to separate it out. We want to keep that where it is. You staple it off, and then you start your dissection the usual way. So unlike the previous patient where the thymoma was small, this is a biggish thymoma. And so you should try not to handle it. And this you will see mostly through this video, that we are not trying to handle the thymoma as far as possible. And we are trying to stay a little away from it, and trying to see whether there's a plane. Now, if there is no plane between the gland and the pericardium, then you have to take the pericardium along with it. And for what we are trying to do is go all around it and take the tissues all around it. So now you can see up there will be your sternum, and you will see a pulsating internal mammary there. So now we are going to the opposite side. We are going to, first we complete this incision, pleural incision, and you can see this pulsating internal mammary vessels here, and then join it with the right-sided incision here. So we have kind of made a complete circle around this, and then we'll go to the left side, so that we can take the left horn along with it. Otherwise, sometimes you will end up doing a thymomectomy. If you're not careful, then you will end up doing a thymomectomy instead of a complete removal of the thymus gland. And this particular, all the videos that I'm showing you are of the myasthenia gravis patients, and it is very, so you open the opposite side pleura so that you can visualize the, at some point, the phrenic nerve of the opposite side. And then this is the left lobe of the thymus that is now being dissected off. So we are away from the tumor, and there is the phrenic nerve, and we are now going along it upwards superiorly. And again, the left internal mammary vein is your landmark up, which is going up. Once we have done that, then we come back to this side, and now we'll take down both the horns. And you can see that here. Now here you can see the right phrenic going all along here. And we are trying to hold the tissue, not the tumor, but tissue around it, and keep our dissection going. Okay, the video seems to have, am I audible?
Yes,
Hello?
sir.
Yes, you're audible, but the video is frozen.
Okay, let's see if it works now. So, okay, I will just, so you can see this brachiocephalic vein now in the picture. Okay, I don't know what can I do about it. And then these are the upper horns being taken down. Yes, the video has frozen. Now you can see here the brachiocephalic vein coming to view. So effectively you take down both the horns as I showed you in the last video. And here you can see the whole of brachiocephalic has been kind of cleared, and then eventually you will remove and now you see the gland, the last bit of the gland being taken down, and then it is bagged. Okay, fine. Okay, you see that now? the whole thing has been cleared off.
Beautiful.
And then the tumor is bagged, and then we kind of take it out. Now, so okay. So what this shows is that this is a patient where we had a very infiltrative kind of a lesion, and it was not biopsied earlier because it was a very flat kind of a lesion, but we had a doubt, so we took the pericardium along. So this is video is showing that if you have any doubt, take the pericardium along so that there's a en bloc, and eventually it did turn out to be a thymic tumor. Now this is, so what about the phrenic now? Now this is again a very large tumor where we had phrenic nerve, which is very close. And also again, as you can see here, the lung going into it. And just to show you that again, we took the lung down. And first you deal with the part which can be easily dealt with. Now it's a large tumor, and first we are trying to mobilize around it so that, you know, you get something to hold on to it. And then you see that now this is the right hilum, and then here we see that it is, you know, the phrenic will come here and it is going to be pretty close to it. So this is where we started dissecting with scissors, and we realized that, okay, this is the phrenic going, and slowly we were able to separate the phrenic nerve and save it. And again, this is a myasthenic patient, and since there was some plane, with careful dissection, we were able to save it and then take the tumor out. So that you can see that again, the tumor is bagged and taken out.
Prof, I think we are a little bit short of time. So
yes,
we can run through this video that we
okay, so this is how you can see the subxiphoid incision. Now this is the phrenic nerve which is involved, and in this particular case it was divided both above and down, and then the phrenic nerve was taken along with the thing. Now, so I'll skip this video in the interest of time. So this is what you see, that the phrenic nerve being divided. What about robotic thymectomy? Now this is a patient who had this tumor, and then myasthenia, and then subsequently this kind of vanished, but since he had myasthenia gravis, so this is a you know, robotic thymectomy in progress. And now this will just give you an idea how a robot can help you, that it's easy to go into the nooks and corners. And if you have time, then I'll continue with it, otherwise I'll skip it, because this is about a 3-minute video.
Oh, that should be good. That should be great.
Okay, so this is showing the robotic dissection. And this is, he had a very odd kind of a configuration, and now we're going along the principles remain same, that you have to take everything from this phrenic to that phrenic, and that you will see shortly, and then you have to take down, and here you can see some lymph node will also appear. This is the left internal mammary, and so you can use this gauze piece to do. So this is already the brachiocephalic is in view, and then you are using this bipolar device to do the dissection and take down the horns and move further. Let's move further. And now we are going above. And so this is where, you know, you have some advantage of these robotic instruments. Not that you can't do it with the VATs, but yes, it does give you, and you can see a lymph node there, which we are now going to take, and the assistant will bring in a harmonic, although we have robotic harmonics also, but if it's available, you know, we have a bit of a problem of availability. So this is assistant coming in and, you know, taking the lymph node out, and then you proceed further, and then, you know, you see here how these instruments with you know, a lot of movement, angulation that you can do, and eventually you take down both the horns. As you can see, there's the right and the left horns, and then you take them down, open the pleura, opposite pleura, so that you can see the opposite phrenic nerve, which we'll see in a second. And then this whole brachiocephalic vein has been taken, and you go right till the opposite pleura. You can see here, and you will see the last bit that I'll show you, the opposite phrenic, and you go till there, and then we'll stop. Here you see the opposite phrenic nerve here, and then you take down everything. These are your specimens. Now, if you have a situation like this, of course, this is not suitable for any minimal invasive. It should be either abandoned or converted to open, and then you can give neoadjuvant. Better is to abandon. We actually abandoned this, sent him for neoadjuvant. Now, the MIT has been increasing over the years, as you can see here. What about the functional outcomes with respect to, this is a very small randomized trial, only there are no randomized trials which are comparing the things. So I'll just show you a few slides comparing in which they found that PFT dropped to 35% in VATS and 65% in stenotomy. But by day 3, it had recovered in patients with VATS, where with the stenotomy, it was still bad at day 3. So just to say that, okay, VATS helps. Now this is MIT versus open thymectomy for thymic malignancies, the meta-analysis. What they conclude is median blood loss and LOS less. But if you look at the median blood loss, about 50, 60 ml here and there, it may be statistically significant, but it doesn't really make much of a difference to the patient. And you see here the length of stay, 9 days in open and 8 days in MIT. That's like too much. We are not keeping patients for 8 days. So there are some fallacies with these studies, meta-analysis. They are retrospective and heterogeneous group of patients. But nowadays you're talking about 2-day, 3-day discharge, and here they're showing 8 days with MIT, which is a little heavy. Again, another meta-analysis of 14 studies, 1,000+ patients. And again, what they conclude is that blood loss, need for transfusion, ICD duration, hospital stay, etc., is better with VATS. Again, remember, no head-to-head comparisons. This is a national analysis of open versus MIT for stage 1 to 3. And you see here the median length is more or less 2 to 4 and 3 to 6. So when they did a, kind of a propensity score matched analysis, they did not find any difference. They say MIT is associated with shorter length of stay compared with open. Otherwise, no significant difference in margin positivity, mortality. And what about oncological outcomes? Now it looks MIT is better, but then again, these are retrospective analysis, ITMIC database. Obviously, people have chosen patients, smaller, better patients for MIT. And when they did a propensity match, of course, there was no difference. And what they concluded was MIT can achieve R0 resection for thymoma similar to those with open thymectomy. And surgical approach per se is not, associated with completeness of resection. Again, another meta-analysis, systematic review and meta-analysis of 30 studies, no difference in disease-free and overall survival. But you must remember that these are chosen patients for MIT, so that has to be taken into account. Similar kind of a thing in VATS and RATS, no difference between both techniques, RATS safe and feasible. Oncological outcomes were not measured in this systematic review. Again, another meta-analysis and systematic review, 7. This is VATS, RATS, and open. And they say RATS versus open, less blood loss, complication, hospital stay. RATS and VATS, similar outcomes. So,
Prof, I think we are
now just
time a little bit, so if you can summarize and conclude.
Yes, I'm summarizing. So, in summary, MIT is safe in selected patients when performed by experienced surgeons. There are no randomized trials comparing MIT with open. Reported studies have heterogeneous patient population, high risk of selection bias, reporting bias, and bias due to unequal surgeon experience. Long-term oncological outcomes are awaited, but it is here to stay. There are many minimal invasive procedures which are cholecystectomy you take, for example, no RCTs, but it's become the gold standard. So it is here to stay. Time will, tell. Thank you very much for your patience and hearing. Thank you.
Thank you very much, Prof, for a very well done talk. It's important that everyone understands the surgical principles of handling a thymoma and performing a proper thymectomy with all the correct template, and the importance of not handling the tumor and doing the appropriate approach, whether it be VATS, RATS, or open. So there's one question from the audience. What is there any particular size limit beyond which you wouldn't adequate doing a minimally invasive thymectomy?
So when we started off, we were, around 3 centimeter. Then with experience, we did 4, 5, 6, 7, and the largest I have done is around 8, 9 centimeters. I think it's the invasiveness of the tumor that actually makes a difference, because sometimes you can have a very large tumor, but it's kind of a hanging. I actually had a video clip which I didn't show because of the time. A seemingly very large tumor, but it's kind of hanging, and you can just take it out. But if you see on a CT scan or an MRI an invasive kind of a tumor, then I would not, at least with my experience, I would not make an attempt to. As long as pericardium is involved, no problems. Phrenic involved, no problem. Bit of lung involved, not a problem. But if SVC is involved, if the heart is involved, the myocardium is involved, if the brachiocephalic is involved, I personally would not, like to go for.
So
and the second,
what you're saying is beyond the size criteria, you would be going by the CT imaging and the pathology of the tumor as well before you decide to approach the patient. And depending on your experience and the skill level of your team,
you have to tailor it to that.
Your approach. Thank you very much, Professor. That is a really excellent talk for everyone. Alan, big round of applause from the entire audience. I'm sure you've been doing my job and answering everyone's questions by the side. I'm really grateful, and the entire team is very grateful for you answering all the questions.
Just saving time.
So, we kept the audience waiting. Khalid, I kept you waiting also. We have overstepped the time a little bit, but there are still around 140 people around, and they seem to be keen and waiting. If you can show me also, and the others, the mediastinal anatomy video and the nerves, which I think is important for everyone, we would be really grateful. Are you up to it?
I've got the options are you're not interested in systemic nodal dissection because that's in the public domain.
Right.
What you are interested in is the anatomy or how to avoid injury to the recurrent laryngeal nerve.
The anatomy would be the best, I think.
Just general anatomy.
Yes, it would show the nerves also, I guess.
Yes and no.
So I think the nerves is better. Nerves is better.
Yeah, I would agree that let him show the nerves. That is
nerves.
That's very important.
Nerve.
Yes.
The recurrent laryngeal nerve. Yes.
Yes.
Okay. Let me just.
So we got a little bit of extension. How much time will you take, Khalid, so I can inform the?
I can sort of. How much time do you want me to speak?
I don't know. 10, 15 minutes.
Yeah, but
15 minutes should be okay, sir.
15 minutes will be fine.
Fine.
Right.
In the meantime, there is one question from the audience. If small tumor of the thymus in one lobe, do you still consider removing whole thymus? Prof. Rajendra, I think it's for you.
Yes. So that was a question. Now I did address this very briefly: thymomectomy versus thymectomy. I think patient is fit, otherwise not a high risk. As of today, I would still do a complete thymectomy.
Okay.
But there is a debate in very small tumors whether you, and I gave the reason because thymus has a role in this T cell production, and post bone marrow transplant, if you are doing a bone marrow transplant, then you need thymus to kind of for the maturation, and that is how this problem happened, and that is how this debate started. If patient has myasthenia, definitely you have to do this. Studies haven't really shown that if you just do a thymomectomy, the myasthenia incidence is too much, but that's a concern always, that whether this patient is going to go on and develop myasthenia. But as of today, I would personally prefer to do a complete thymectomy in a fit patient.
On to the International Association for the Study of Lung Cancer 2009, IASLC in short. The bipolar device LCL is used routinely for nodal dissection. In the right test, we start with releasing the
Can't find what is causing the thing. Oh, dear, 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 dear. Hello, can you hear me?
Yes, sir.
Yes,
I
sir.
think Dr. George, I think, disconnected. He's connecting back.
Yeah, we can hear you, sir.
Okay.
Yes, sir, we can hear you, sir.
If I try to again share my screen,
Sure,
this
sir.
one.
Yeah, we are getting it, sir.
Am I sharing my screen?
Yes, sir.
Can you see my screen?
Yes, sir, we can see, sir.
Okay. Right. This is mainly about the laryngeal nerve and
Yes,
how the surgeon, the thoracic surgeon, should know the anatomy of the recurrent laryngeal nerve extremely well before you can actually understand how you can avoid injuring it.
Avoid damage to the laryngeal nerve with little heart. It's imperative to understand the anatomy of the recurrent laryngeal nerve in great detail before
Okay.
providing
It is narrated, but I'll try to narrate over my narration.
one has to understand the course of the wide vagus nerve.
I'll probably, this is the theory behind it, but I will skip that. Let us do the exposure on the right-hand side of the chest. I don't know how to reduce that. There again, the exposure of the recurrent laryngeal on the right-hand side starts with this, what I call the superior triangle, which is the space between the phrenic and the vagus. So you open up the pleural reflection and you dissect the station 2 to 4 completely. And that exposes for you the base of that triangle, which compromises the arch of the aorta and the brachiocephalic. So this is what you should make sure of. Okay. As you can see, this is the aorta, and this is the origin of the carotid artery. You don't see this usually unless you dissect extremely well. And this is the vagus and its recurrent branch crossing the brachial plexus. The way to understand the path is to follow the vagus proximally, and you follow the brachiocephalic artery proximally, and at their intersection you will find the recurrent laryngeal nerve like that. This is the area where you should avoid totally any diathermy. You will find those small twigs. These are all sensory nerves, and you can cut them. But how can you differentiate between those small sensory ones and the motor one? The motor one is fairly large, and it's quite tucked to the brachial artery. So it doesn't go away from the brachial artery for a very long distance. This is where you should have a look at it. And if you acquaint yourself or your eyes with the size of the recurrent laryngeal nerve, then you will understand. I usually mimic this to fish in a fisherman's trap, these lymph nodes, which are 3A, 3P. And you can't cut these, nerves coming from the vagus and from the recurrent with impunity. You have to use a bipolar diathermy to do that. Unipolar is disastrous in this area. If you have to use anything, it will have to be a unipolar. I use NSEAL, which is an extremely revolutionary device for me. Again, this is going to the back to 3P nodes, and this can be cut again with impunity. On the left-hand side, it's slightly different and it's more complex. And again, I have divided the path of the recurrent into 5 zones. The one that's from the base of the skull to the arch of the aorta is zone 1. Zone 2 is over the arch. Zone 3 is under the arch of the aorta, and zone 4 is at the tracheoesophageal groove. And then the zone 5 is where it's supposed to do its job in the larynx. So in zone 1, you should find it between the subclavian artery and the subclavian vein. The common vagus, which is the descending vagal trunk, comes somewhere in between these two and under the vein, which is the first intercoastal vein, and that you can cut with impunity. You can see here I have made a mistake. I have taken it lightly, and I have cut the trunk of the vagus inadvertently with the diatherm, and this will definitely lead to recurrent laryngeal nerve injury. Like this, you have to really be very careful. You should only cut the pleural reflection. Anyway, when you come to zone C over the arch of the aorta, you will notice that the recurrent comes on the right-hand side of the vagus, and it's about half of its diameter. Again, in the same superior triangle between the phrenic and the vagus. The way to expose it on the left, you will have to take out the station 5 and 6 lymph nodes, because this is the only way for you to see the ligamentum. And you need to see the ligamentum arteriosum very clearly to avoid cutting the recurrent laryngeal. And in the recurrent laryngeal, you're really interested in the motor branch. Those little small branches, which sprout here and there, are not important. You will also see that there is a mid-space inferior cardiac nerve coming from the vagus. It's constant right and left. Amazingly, you can cut it with impunity. Again, quite away from the ligamentum. Once you can see the ligamentum, and here's the ligamentum, then you are free. I usually don't cut it, but if I know that there are large lymph nodes in station 4L, then I cut it because it makes the dissection easier. And you have to be very aware of the motor branch. This is what it is. This is your recurrent laryngeal, and this is the motor branch. This is what I call zone 3. And this is what you should look for. You will also notice, just like the right side, there are these sensory branches sprouting from the recurrent and from the vagus, exactly like before, like the right side. These you can cut, but you will have to train your eye to see them. The recurrent is large. It's about at least 1 millimeter in diameter. It's half the breadth of the vagus. Whereas these very small twigs, and they usually, you can see them going into the lymph glands and to the pulmonary artery and what have you. You can cut them with impunity. There is a great similarity between right and left. This is exactly the same arrangement at the reflection point of the recurrent laryngeal when you start getting these sensory nerves, and you can cut them all with impunity with a bipolar. Again, the similar thing. 4L, they look like fish traps in a fisherman's net. As I said earlier on, all the sensory you can cut, but this is the one you should look for. You should not cut the motor one. So keep an eye on the motor one. Again, bipolar, use bipolar. If you don't use bipolar, do not come near this area. Do not approach the recurrent. This is human cadaver specimens that we have dissected in India in the Ames, in which we have cut the arch of the aorta between the subclavian and the carotid to have a look at this recurrent laryngeal path, and it's very clear. We have made this sort of relationship with what is motor and what is sensory, and we've got this concept of one should only follow the motor. That's exactly the plane where we have cut the arch of the aorta to see this recurrent going into the groove between the trachea and the esophagus, tracheoesophageal groove. And this is actually, the esophageal surgeons see this extremely much more than us. On the right-hand side, when they flip the patient prone to do their esophagectomy, they cut the azygous vein, and they see this very nice view between the esophagus and the trachea, and they dissect the recurrent laryngeal nerve. This is, by the way, the left recurrent laryngeal nerve, not the right. And it's very clear, you can see it here. about half a 1 millimeter diameter nerve. And they cut all the twigs that are going off it to the different structures with impunity. Either they just cut it with the scissors and accept the little bleeding, or they are sometimes very careful. They use monopolar diathermy in a way which will not affect it. We have also had similar experience when we were doing and seeing the recurrent laryngeal nerve. We've been using bipolar energy to dissect the lymph nodes near the recurrent laryngeal nerve. It's imperative that you should use a bipolar device, otherwise the spray of energy will guarantee thermal injury. So as I said earlier on, you can disconnect all these nerves. This one, for instance, you can see very clearly that's supplying the wall of the trachea. It's a sensory nerve. They can be cut with impunity. One specific sensory nerve is very consistent. Again, what you should also know is that the recurrent goes into this groove, the tracheoesophageal groove. So it curses to the right-hand side of the reflection points, not to the left. This little nerve here is a constant cause for confusion. And thoracic surgeons just dread it. They don't know, what is this? Should I cut it? Should I not cut it? This one, I always cut it. And the reason for that, this is not the motor branch. This is a sensory branch, usually going to a lymph node or to the pulmonary artery. Here it is. And you can see it's going to a 4R lymph node. Don't be afraid. You can cut it with impunity, as you can see here. That's it. If you haven't seen it, you can guarantee this is Mr. Ramos did this before and he had no problem. Again, when you're dissecting lymph nodes that are quite stuck to the motor branch, if anything is stuck to the motor branch, do not apply energy of any kind. Just peel it out and accept the little bleeding that comes out of it. Again, I emphasize that you shouldn't cut anything unless you have made up your mind. Is this the recurrent laryngeal motor branch or not? So this one is going to a lymph node and I can see it. So I'm disconnecting it close to the node. Now 2L are difficult, and in the 2L area, which is a diamond-shaped area, it's between the subclavian and the carotid. In this area, you'll find 2L nodes, and behind them would be the main trachea. Again, the vagus here comes from lateral to the common carotid and crosses to the subclavian, just exactly like the right side. It's typical, it's the same. And we understand that the ascending part of the recurrent laryngeal nerve will go behind the subclavian. So if you dissect the subclavian a little bit to the left, you will find this ascending recurrent laryngeal nerve just behind it. So the landmark to the ascending recurrent laryngeal is the subclavian. If you dissect below it, you will find it. And as you can see, the size of it is quite sizable. It's about 1 centimeter in diameter. You cannot mistake it. You cannot even cut it inadvertently. So this is trachea here, and this is the carotid artery and the subclavian, and this is just to show you that cutting the recurrent laryngeal can cause paralysis. I think that will probably suffice for the recurrent laryngeal, and I can probably take questions if you have any.
Hello.
Is that all right?
Thank you very much, Khalid. That is a wonderful demo. I wish you would make this video part of the standard teaching module for acrostic thoracic surgery, because this is one of the most nuanced dissections of the nerve which I've seen, and which is essential teaching for most lung and thoracic surgeons. I think you should make it freely available. That's my request.
That's why I requested earlier on, or at the end of my my presentation, if you remember, if
yes,
people subscribe, all these videos, all of them, they're going to be in that thing. There is a specific one about bronchoscopy. which teaches microscopy. I think this is very educational.
I'm sure our audience enjoyed it tremendously. Thank you very much, all the faculty. They were really excellent. Balu, do you want to make any concluding statements?
Is there any further questions, or we can conclude, sir?
Of course you can.
George, sir, any further questions to be answered, or we can conclude?
Nothing. See, what's happened is my device shut off, so I'm using my phone. I can see the chat.
Fine, sir. Fine,
but
sir.
I think it's quite, and it's been brilliant. As an, I must.
I think we lost him again.
Yeah.
Yes, sir.
You can conclude.
Yes, sir. If there's nothing more, then I thank the college, our university, for having granted us the permission to do this. Our head of the department, Dr. Jagadish Chandra Bose, and I also thank all the faculties who have taken pains to join us on this Sunday and share their experience to all of us, and especially Professor George. All of them agreed on just 2 weeks intimation, and it was a very short period, and I'm very thankful that they could help us out on. And not the least, I thank the Merrill, the company sponsored for the whole event, and all my colleagues and all other people, and all, especially Dr. Manjunath, who had been there with this in AIMS, and who has also helped us get all the faculties and things on board. Thanks once again. Thanks a lot, sir.
Thank you very much, everyone.
Thank you.
Thank you, sir.
Thank you so much.
Very well.
See you, Alan. Bye.
Sure.
Bye.
Thanks.
Bye.
Bye.
Dr. Khalid. Bye, Dr. George.
Thank you, everyone. Bye-bye.
Shall I stop live stream, sir? Bala, sir?
Sure.
Thank you.
Thanks.
Okay. Thank you so much,
Thank you, sir.
George, sir. Thank you, all faculties. Thank you, Bala, sir.
Thank you, sir. Thank you.
Thank you all. Thank you all, sir.
Thank you all, sir.
Thank you all.